This is a video on Economics, Chapter 7, the Economics of Healthcare. So we're going to talk about improving health of the people in the United States, healthcare around the world, information problems and externalities in the market for healthcare, and the debate over healthcare policy in the United States. So healthcare expenditure in the United States is higher than anywhere else in the world. Why do you think that is? What's the reason? Is it the high quality of healthcare? Is it the system of payment? Is it the higher demand? One of the things I didn't put on here that I think is a driver is it about innovation in healthcare as well? So new and experimental drugs and procedures and equipment. So in this chapter, we'll talk about some of the elements of healthcare that make it a rich field of study for economists. Healthcare is the goods and services such as prescription drugs, consultations with doctors, and surgeries that are intended to maintain or improve a person's health. So, talking about healthcare in the United States from 1850 to 2015, the last couple of centuries have brought incredible advances in healthcare outcomes. Part of that is about improvements in nutrition. Then the public health movement, late 19th century and earliest 20th century, improvement in sanitation, food distribution, etc., and feedback from better health to higher incomes to better health. So, in 1850, our life expectancy at birth would have been 38.3 years. The average height of an adult male would be 5'7", and infant mortality, so the death of a child age 1 or less, is 228.9 per 1,000 live births. Now, 2015, it's 79.6 years is your life expectancy. The average height is 5'9.5", and there's 6.2 per 1,000 live births infant mortality rate. So some of the most dramatic has happened. As you can see, during the Great Depression, there was a dip in life expectancy, of course. Nutrition, wages, stress, all kinds of things, right? Famine. So we go up here, and then we've made huge strides in life expectancy, right? Correspondingly, there's a decrease in the death rate adjusted for life expectancy. So, improving healthcare. Death per 100,000 people. So all causes are on their way down. Cardiovascular disease has had a significant decrease, but cancer's remained about the same. But look at the death from diabetes or obesity-related things. Kidney disease, liver disease, and diabetes. Why might that be? So there are important differences in healthcare around the systems of the United States and those of other countries, both in terms of who provides the healthcare and who pays for the healthcare. Most healthcare in the United States is provided by private firms and paid through health insurance. Health insurance is a contract under which a buyer agrees to make payments or premiums in exchange for the providers agreeing to pay some or all of the buyer's medical bills. Insurance payments can take the form of fee-for-service, where the doctors or hospitals receive a payment for each service they provide, or an HMO, or health maintenance organization, where doctors receive a flat fee per patient. So if you think about it, in 2014, about 55% of people received health insurance through their employer, and 36% of people received it through government programs. Then we have Medicare and Medicaid, individual insurance, and of course the military health. And this is provider-based, so individual is you're buying it in the marketplace. About 10% of Americans had no health insurance in 2014. Now, remind you that there was a mandate to have health insurance, but why might people pay the penalty instead of getting health insurance? The proportion of Americans without health insurance is lower now than in recent years, partly because of the Affordable Care Act. This law enacted subsidies for lower income people and introduced penalties for not having health insurance. However, many people still do not have health insurance, typically because they either can't afford it or because they believe it's unnecessary and they are healthy. A lot of the people who remain uninsured are younger, but the expansion of being able to stay on your parents' health insurance until 26 has reduced that number. So, making the connection, let's talk about it. In 1990, manufacturing was the largest source of employment in the United States. In 2000, manufacturing was still the largest employer in 27 states, but healthcare had become the largest employer in 2 states. And in 2014, manufacturing was the largest employer in only 7 states, and healthcare was the largest employer in 34 states. And with the baby boomers retiring and needing more care, that number is just going to increase, right? In most states, healthcare industry is now the industry with most workers. The Bureau of Labor Statistics forecasts that 13 of the 20's fastest growing occupations over the next 10 years will be in healthcare. So let's talk about some other countries, because we always have this conversation and you hear it in the news. Well, why can't we have healthcare like whatever country? So in Canada, they have a single payer healthcare system. Healthcare is provided by private firms, but paid for by the government, indirectly via taxes. Individuals pay nothing for out-of-pocket services. But there are some downsides to this. Extremely long waits is one of them. Japan, they have universal health insurance. Every resident is required to enroll in a nonprofit health insurance society or enroll in the national government's program. Individuals have substantial copays in Japan. In UK, they have what would be called socialized medicine. It's a healthcare system under which the government owns most of the hospitals, employs most of the doctors. Some, greater than 10% of people, supplement with private insurance, or actually some is less than 10% of the people. So, levels of income per person and spending on healthcare. Healthcare is a normal good. The more income we have, the more expenditure we're willing to pay on healthcare. But the United States spends a greater portion of income per person on healthcare than other countries. So I think there's a lot of factors. I think, we can blame it on lots of things. Part of it is the insurance paying system. Part of it is probably our litigious society that, so malpractice insurance is crazy expensive, right? Part of it is that we're innovating. A lot of the things that happen over here in all these other countries happened because we came up with a new drug or we came up with a new process, because in our society you can make money off of healthcare. And so there's incentive to innovate. So we spend significantly more per person than any other country. And one would say frequently that we have not great outcomes considering we spend more. But I also bring up the idea that we are willing to save babies at a much earlier time, or go to different lengths for all kinds of different people, because we have that choice, right? So life expectancy. So ours is 79.6, Canada is 81, Japan is 82.7, United Kingdom. So we have the least in the developed countries. Male life expectancy at age 65, so 17.8 years after 65. Female life expectancy is 20. Of course, females just generically live longer than males here. Infant mortality. So we have the highest infant mortality, deaths per 1,000 live births. But I wonder what age or what number of weeks inside a pregnancy that someone is going or willing to extend. Sorry, click the screen. So next, we have health problems, obesity. So obesity is affecting 33%. So we have the highest obesity rate. One might argue that health insurance is an incentive to become obese because we don't really pay a lot for our medical care. We pay, the insurance pays. Then the number of MRI machines per 1 million in the population and CT. So we have, we're higher than everybody but Japan. And the number of deaths from cancer. So ours is higher than Canada and Japan, but not the UK or the average. And the risk of dying of cancer is 11% before the age of 75. And the mortality ratio for cancer, ours is lower than anybody else. That's because we spend a lot of money on cancer research. However, comparing across countries is often difficult. So the reasons that comparing healthcare across countries is potentially misleading is because data problems. Countries may not collect data in the same way. Problems with measuring healthcare delivery. How do you measure the quality of care? It's very hard to measure quality of care. Are we getting better care? Are we receiving more tests? Do we just over-test because we're afraid of being sued? There's a million different potential reasons. How do you measure quality? Lifestyle choices. Obesity and diabetes, for example, may have more to do with choices of consumer than the effectiveness of the healthcare. Yeah, you'd have to change people's behavior. Problems with determining consumer preferences. There's a disconnect between prices people pay and services received. There is a disconnect in healthcare. So these are all data problems, problems measuring healthcare delivery, lifestyle choices. These are all problems. So also information problems and externalities in the marketplace. The healthcare market is characterized by asymmetric information, a situation in which one party to an economic transaction has less information than the other party. This can lead to market failure, the inability of the market to maximize economic well-being. The two main forms of asymmetric information are adverse selection and moral hazard. We're going to talk about this. Adverse selection. Suppose you are looking to buy a used car. If someone offers to sell you a used car, would you believe the car is high quality and the seller just happens to want to sell it? Or the car is low quality, a lemon, and is trying to sell it and unload their problems on you? I'm probably going to go with the latter. If you offer a moderate price, then people with a low quality car will sell to you. Because without further information, you don't want to buy a car from anyone who's willing to sell a car to you. As Groucho Marx said, I don't want to belong to any club that will accept people like me as a member, right? So the problem with this is in the healthcare market, adverse selection is the situation in which one party to a transaction takes advantage of knowing more than the other party to the transaction. The people who want health insurance are the ones who are likely to use it. The people who opt out of health insurance feel they're healthy, right? So the premiums need to be high to cover these expected costs. But now people with only moderate needs may find health insurance too expensive, causing them to drop out. This problem is lessened if people are very risk averse, wanting to avoid risk. Even though I would say, I feel like I'm generally healthy, I wouldn't want to be on the hook for a huge medical bill, so I probably wouldn't opt out of health insurance. But I'm risk averse for that. Health insurance companies have tried to lessen the impact of adverse selection by excluding pre-existing conditions. That is no longer allowed based on the Affordable Care Act. It is a normative value judgment question whether the gains for society through avoiding adverse selection outweigh the cost of society through reductions in health insurance coverage. An alternative way around adverse selection is to mandate individuals to carry insurance, which is what we did, right? Most states require automobile accident insurance. The difference is that you don't have to have a car. You could take another form of transportation. But what about health insurance? This is just like saying you have to buy this. So talking about a moral hazard in health insurance. Moral hazard refers to actions taken after entering into a transaction that make the other party to the transaction worse off. Example, people with car insurance might drive less carefully knowing they are financially protected if they crash the car. Moral hazard. People might use health insurance healthcare more when they don't have to pay for its full cost, going to the doctor unnecessarily, engaging in risky behavior, accepting excessive treatment options. Such actions would increase the cost of healthcare to society, perhaps without providing substantial benefit. So the financial structure of insurance contracts may make doctors change their behavior. So this is what I was talking about with the situation with I'm going to get sued. Or they're not going to pay for this if I didn't find this. So ordering unnecessary tests and procedures to protect yourself, and since patients pay little out of pocket for additional care, they're likely to agree to the additional treatment. But this drives up the cost on the insurance company. This illustrates the principal-agent problem. A principal-agent problem is a problem caused when agents pursuing their own interests rather than the interests of the principals who hired them. In this situation, the doctor is the agent, and the insurance company is the person who hired them. The insurance company must delegate decision-making power to the doctor, who may not have the same interest as the company. Do doctors succumb to moral hazards? What do you guys think? Well, the number of medical procedures has been increasing. Doctors tend to claim they don't order extra tests and procedures for financial gain, but either out of genuine concern for their patients or defensive medicine to avoid malpractice. The key to dealing with moral hazard is to try to make sure people don't change their behavior too much. The way that we do it for patients is deductibles. The patient pays the first X amount of treatment costs, or coinsurance. Coinsurance would be Medicare is an example of coinsurance. Like after the deductible, you're responsible for 20%. That means the insurance company is 80, but you still have to pay for every test. Doctors, they standardize payments for particular industries. Such methods reduce but do not eliminate moral hazard problems. Recall that external costs or benefit will result in market failure because from society's perspective, the wrong quantity will be consumed. Positive externalities. So vaccinations reduce the chances of other people getting sick and healthy population for good for employers. So if everyone's healthy, there's fewer sick days. The way negative externalities would be is poor health choices like obesity and smoking are paid for by others, high premiums and taxes. So here's an example of how we assume people pay for the full price of vaccination. So here's market equilibrium. This is demand and of the marginal private benefit, and this is supply. Vaccinations have a positive externality, so it increases demand, market equilibrium. Consumers will purchase vaccinations. So this is dead weight loss. This is a positive externality, and this is considered dead weight loss in here. So should the government run the healthcare system? If healthcare were a public good, that would be a strong argument for the government involvement. Is healthcare non-rival in consumption, non-excludable? Neither of these seem likely, so healthcare seems to be a private good. However, the externalities and information asymmetries may generate enough market failure to prompt government involvement. Overall, the government's role in healthcare is controversial. I was talking about I got a referral for an MRI and I did not know you could negotiate, and I ended up paying $2,000 out of pocket for the MRI instead of, because I have a high deductible, $700 at a different place right down the street. So the Patient Protection and Affordable Care Act was passed by Congress in 2010 but remains controversial. The United States spends more per person on healthcare than any other country without getting better outcomes. And this cost appears to continue to rise. What should we do about this? We'll explore this in another topic. This is healthcare as a percentage of GDP. It is projected to continue to rise. These are other countries. This is the United States. Look at how far we outpass these countries. At the same time, Americans are paying smaller and smaller portions of their healthcare out-of-pocket costs. Think about this. Americans would likely not choose the same level of healthcare expenditure if they had higher out-of-pocket share. Combined with rising costs, this presents a particular problem for government budgeting. Why are healthcare costs rising? While paperwork is it's not increasing fast enough to explain the rise. Malpractice, it's significant. Congress Budget Office says 1% of economists estimate it to be 7% of total healthcare, but again, not rising fast enough. Uninsured patients. The increase costs 1 to 4% from getting treatment in the wrong places, emergency room versus the doctor. Still not rising enough. Service providers like healthcare have not seen huge productivity gains like manufacturing. Labor productivity in healthcare has risen about half as much as the economy as a whole. But in order to keep workers' wages have risen in the service sector, including healthcare, of course. This is known as the service sector cost disease. So I guess the point is that rising wages in the field is outpacing everything else, the idea that they're getting at. So the primary reason, number 2, is aging population. So the reason for federal spending on Medicare and Medicaid, older people require more health care, and as medical advances keep people alive longer and birth rates slow, the elderly population will continue to rise. However, this graph shows from the CBO the effects of the aging population should not be overstated. So this is what they're saying that federal spending is because of aging population. The rest is excess cost growth. Primary reason number 3 is distorted economic incentives in healthcare arising from insurance. So what they're saying is there's a disconnect between the service and payment means, and consumers have little reason to accept services for lower costs. Now, I have a high deductible, so that's an incentive. If I didn't have a high deductible, I probably wouldn't know that you can get an MRI for way less money someplace else. The overconsumption of healthcare creates dead weight loss. This is the dead weight loss. So continuing the debate over healthcare policy. Extending healthcare coverage to be more universal has been attempted and rejected several times. In 1945, President Harry Truman proposed the National Health Insurance. In 1993, Bill Clinton proposed a universal public-private plan. Each time, Congress has declined to enact the plans. In 2009, President Barack Obama proposed significant healthcare reform in the form of the ACA. In March 2010, Congress approved. Scheduled to be fully implemented by 2019, the individual mandate to obtain health insurance is part of this. The state health exchanges to increase access to policies. Employer mandated for most firms to provide health insurance. Regulation of health insurance altering how health insurance companies can act. Expansion of Medicaid eligibility and Medicare cost control. And increased taxes on high-income individuals, high-cost insurance plans, and some healthcare-related industries, like medical devices. The debate over this. So the ACA is expected to increase healthcare coverage to 30 million. The CBO estimates that the federal spending will increase about $2 trillion from over 16-15. As a result, with taxes and fees reducing the net increase to 1.4 trillion. Debate remains over whether the ACA is the right approach for America. And this is going to be our debate. We're gonna debate this online. So emulate the Western countries with more government control, or adopt the more market-based reforms. So making healthcare act more like normal goods. Insurance does skew this acting like normal goods. If a well-functioning market, competitive forces will help to keep prices similar. Consumers would shop around. Look at these MRI prices. There's huge differences. Like that was my example. I had no idea. But when your doctor tells you to go somewhere, you just kind of think you have to go there. I think there needs to be more education about shopping things around. With healthcare expenditure projected to consume almost 20% of national income by 2020, we must find a way to control costs. Are people willing to accept service reduction in exchange for cost reduction? Or can we find a real way to reduce costs without giving up quality or quantity of healthcare consumed? This is a heated topic that will sure to remain